Hey, hello everyone. My name is Jennifer Wilson and I'm the Executive Director of Cassie and Friends. And we are excited to welcome you back. We haven't done a virtual education series in a little while, and we are really excited to get started on such an important topic. So today we're going to be talking about the jaw joint and tips and tricks for a healthy jaw in children with juvenile arthritis. And this is a really important topic because, as we shared yesterday by email, 8 out of 10 children with JIA will likely have a TMJ joint complication. So this is a great topic to dig into and educate ourselves. Before we get started, I just want to give a big thank you to our sponsors, the Arthritis Society, Nicola Wealth Management, AbbVie, Amgen, and Sobi. These sponsors help to make virtual education possible for our community. And to date, we have had over 300,000 families across Canada join us for a session or view our sessions online. The cool thing about these virtual education sessions is that if you don't catch them live, you can always go to our website or review ones that you've watched before. And we have such a wide breadth of topics that families have told us are important to them. And all of these sessions featured a patient speaker or a parent speaker to share their life experience or what they endured. And then we also have expert speakers. So if you are starting a new medication, thinking about uveitis, back to school, and thinking about sport, I really do encourage you to check out our virtual education library. Besides the virtual education recordings, each session has helped us to create an amazing online resource center called Classroom. And so you can see here on Classroom, it's a growing index of not just the recordings, but the patient and parent submitted questions and the answers. We've also time-stamped all of the sessions so that when you're watching a recording, you can skip to the information you're looking for. As a result of this session today, we're going to have an amazing resource page on TMJ. So I encourage all of you to check back there if you have any questions or want to review what you heard today in the future. So we always like to get started by inviting people to introduce themselves in the chat. I was taking a little look through the participants, and it was so nice to see some familiar names and also some brand new names. So why don't you take a second, introduce yourself, let us know where you're from. As you can see, we have representatives from 38 countries or cities and 4 countries listening to the webinar tonight. And I definitely see a few fans of our patient speaker, Emily, in the room as well. Cassie and Friends has a private Facebook group, and this slide is actually a little out of date because I believe there's almost 520 members, and each and every member is a Canadian parent or a young adult or youth with juvenile arthritis or another rheumatic disease. So this is a really private, secure place that in your day-to-day, if you have a question, a concern, or you want to celebrate a major achievement like tapering a medication or an amazing week with no pain, this is the place to do it. These are the parents, families, and youth who truly can relate to your experience with juvenile arthritis and other rheumatic diseases. And I just love being a part of this community, and I hope everyone will consider joining. For upcoming events for Cassie and Friends, our next webinar is aimed towards a little bit of the younger subset of juvenile arthritis families, somewhere around 2 to 8, though there will be tips for everyone. And this particular webinar touches on a really confusing topic for some parents, and that's when a child is in remission. It's a great time of celebration, but sometimes there can be some confusion around why the child's still limping or still experiencing pain. And so this session is going to go into some of the research around how children learn to move while experiencing joint inflammation, and give some really great tips from a physiotherapist as well as a pediatric rheumatologist on what you can do to help with functional and movement. We also have so many Team Cassie and Friends run walks. If anyone's on the line today, we have our Edmonton run walk coming up September 18th. shortly followed by our London, Ontario, and then Windsor and Toronto. So there's still lots of time to sign up for Windsor and Toronto, and a little bit of time to sign up for London. And this is an amazing place. We're just coming back in person for the first time in a couple years. So we're really excited to be connecting with families again, to have the clinic teams out, and to feel the sort of the magic of Cassie and Friends community coming back together. And this is also an amazing way for us to raise funds to do all the work that we do. And lastly, our Youth Ambassador Program is a brand new program, and we are inviting youth age 17 plus with an idea or a project or a campaign or a service idea who want to make a difference in the rheumatic disease community to work with us. We have mentors. They will receive an honorarium, and they'll also get a chance to be trained as a juvenile arthritis youth mentor to help other kids in the community. So if you have a teen or a young adult in your family, please encourage them to apply. If you have a question at all during the session, there's down below a Q&A button. So there's a chat button and a Q&A button, but put your questions in the Q&A button. And it's one of the best parts of these sessions is the chance to just have a nice conversation at the end, to ask your questions outside of the clinic room in a sort of more casual setting, and to have all of our speakers weigh in. There we go. And so now we can get started. I'm really excited to first introduce our young adult speaker. So Emily Bessey is a really amazing youth leader in our Cassie and Friends community. I looked at her LinkedIn profile because she gave us a bio, and I knew she had a lot more that we should share about her. But in addition to her role as a teen leader, Emily is a very accomplished student. She goes to sorry, just a second. What was it called? St. Thomas University in Fredericton, New Brunswick. I haven't had a chance to visit yet. And there she's studying musical theater and gender studies. She has a huge interest in human rights, and that is evident in lots of things that she's done, from being a youth advisor at IWK to being the only first-year student to receive a really unique summer scholarship from RBC, where she actually got to create her own internship and work at an Atlantic Canada organization. She's also received an amazing scholarship for students with an interest in human rights, and she's been just such a wonderful part of the Cassie and Friends community and so helpful to other youth in sharing her story. So with that, I'm going to invite Emily to turn on her camera. I'm going to turn off my camera and stop sharing, and I'm really excited for you to hear from Emily.
Good evening, everybody, or good afternoon, depending on what coast you're watching it from. It's the evening for me. My name is Emily Bessey. I'm 19 years old. I'm from Cole Harbour, Nova Scotia, but like Jen said, I'm currently living in Fredericton, New Brunswick, attending St. Thomas. I'm taking a double major in musical theater and women and gender studies, and I'm double minoring in human rights and English as well. I'm also the chapter lead for the Teen Arthritis Group chapter in Halifax. And I'm very excited to be here speaking tonight, talking about my experience with arthritis, my experience with TMJ. I'm going to be talking a little bit about my diagnosis experience. A big thing for me with my TMJ is preparation for jaw surgery. So what's that been like? And also just coping with arthritis and coping with TMJ in general. Thank you again to Cassie and Friends for inviting me to speak tonight. And I hope that what I have to say brings some kind of comfort or peace of mind or something to someone listening, whether that be to a parent or to another child who is living with TMJ. A little bit about my diagnosis. I was diagnosed with JIA when I was 6. For me, that started in my knees. I would limp around in the morning, kind of all throughout school, but like that kind of typical presentation of JIA morning stiffness. I would come home at the end of the day walking pretty normally. So wasn't sure. I kind of felt, and we kind of thought that it was some kind of playground injury or something like that. But it wasn't until we really looked at my joints that we realized that something was wrong. It was very swollen, very inflamed. So we went to go see our family doctor, who referred us to rheumatology and as well for blood work and testing. And now we are here 13 years later, and I still have arthritis. At my very first rheumatology appointment was the summer of 2009. So when I was 6 years old. Even though I hadn't complained of anything and we hadn't noticed anything, my rheumatologist did notice upon first exam that my jaw was not normal, if you will. It didn't fully open. One side was opening further than the other, and it also deviated or shifted over to one side when I did open it. So we were referred from there to the oral surgery department at the Chewy 2 hospital in Halifax, which is the adult hospital just right across the street from the IWK. I will say it was very weird being a very small child, very young patient in the adult hospital. I would always get a lot of funny looks when people realized that I was the patient and my mom, who was coming to the appointments with me, was not the patient. All of the equipment, the x-ray machines, the chairs, everything was far too big for me. They didn't actually have any pediatric sized equipment. So there are many photos of where I am standing on like phone books and boxes just to like get me up to the height to like be in the machine. At one of my last appointments in the oral surgery office, they actually pulled me into like the x-ray tech room and they showed me back all of my jaw like progression photos. They showed me like my very first x-rays. You could see like my teeth coming through, and I was very, very small. So getting to see that progression was kind of cool at my last appointment. At the end of that summer that I was diagnosed, they sent me for an MRI of my jaw to see if there was any active arthritis or TMJ damage. But if you know anything about that, you know that the jaw can be a very hard joint to get a clear picture of because it is so small. So an MRI for a 6-year-old like me was very long, it was very loud, very boring, and very hard for me to sit still. We actually ended up, none of the photos we took at that MRI ended up being usable. And about a year later, we got a repeat of that MRI. I also lost a tooth during that MRI. So it was a very interesting day all around. So flash forward a year, we finally get the repeat MRI, which showed that I did have active arthritis and cartilage damage on one side of my jaw. That was treated then with a joint injection on that side. And then another year later, a repeat MRI was done and they found out that I had another active arthritis and damage also on the other side of my jaw as well. I had never complained of any kind of jaw pain or anything when they found the arthritis. But I also think that having arthritis or any kind of chronic pain from a very young age also made it harder to establish when things were painful because I only remembered things feeling that certain way. I don't really have any other kind of recollection. So for me, I didn't know that maybe my jaw wasn't supposed to open like that or joints weren't supposed to feel that way because that was just how it always was. So that was definitely a challenge for me. And I think another challenge with TMJ specifically is that it's not a joint that's very easily accessible to a not rheumatologist or a not oral surgeon's eye. So it's not like a knee where I can kind of tell like, oh, that is looking kind of swollen or that's looking kind of inflamed or it's warm to the touch. The joint is so small and it's so tucked in that it's a little bit harder for the average person to tell if there's something going on. It's also, the joint is just the joint's a weird thing. So we continued to be followed by the oral surgeon, but not actually a ton of medical intervention, if you will, besides treating arthritis with medications and doing the joint injections for the arthritis in the jaw was actually done at that time, just because my jaw wasn't done growing. And ultimately, when your jaw is done growing, most people with TMJ would start looking towards jaw surgery, which is kind of where I'm at now. Along the way, though, we treated it with medication, different suggestions of things to deal with the pain. I remember very specifically being told once that I couldn't chew gum. And I was under the impression when I was told that when I was younger, that I was like, would break my jaw if I ever chewed gum. Like I didn't chew gum until I was like 17 years old because I thought that chewing gum was going to ruin my jaw. They just didn't want my jaw to hurt, but I really understood that as never chew gum ever. So now I'm at an age with my TMJ where the conversation has kind of shifted from hypothetical, oh, we'll cross the bridge of jaw surgery when we get there, to now actually kind of all of a sudden I was in front of the bridge and we were talking about it. So I started seriously talking about the jaw surgery process in September of 2020. It's when I started straightening out my teeth, which is kind of the first step to getting towards jaw surgery. I've prepared for surgery about 3 different times, but unfortunately due to COVID and other kind of constraints within the hospital, I wasn't able to get it. So I'm now tentatively booked, I say, for my surgery for May of 2023. So coming up in this next spring. In terms of advice or guidance that I would give to someone who has arthritis or has TMJ, a big thing that I like to say to people is that you know your body best. You know when things are feeling off, when things are feeling wrong. You know your body's limits and what it kind of can and can't do. Because I know, at least for myself, arthritis has kind of changed my limits a bit. So my limit is not the same as someone else's limit. Advocating for yourself is a very hard thing to do, but it is a very useful skill. And especially when you have a chronic illness, learning to advocate for yourself is a big deal. It was a big deal for me, something I struggled with for a long time and something I'm still learning how to do. It's a skill that I don't think you ever stop really developing. But speaking up for what you need and what you want really is key. So you should be working with your team, trying to find a plan that's best for you. Like, so if you don't feel like something is the right fit, you can ask for other things. You can try and find this common ground, find this thing that works. Any kind of chronic illness, not just arthritis and TMJ, chronic illness across the board is not a one size fits all model where this is going to work and that's going to work and that's going to work. There are going to be some things that maybe they work for other people and then they don't work for you, and vice versa. There's going to be things that work for you that might not work for other people. So it's just really about finding what's best for you and what's going to be best for your treatment plan. That's kind of my spiel on my experience with TMJ. So I hope that that rings true for some of you, but again, it's not a one size fits all thing. So if this wasn't your experience is still very valid and very true. So again, thank you so much to Cassie and friends for letting me come out and speak tonight. And I can't wait to see how the rest of the webinar goes.
Thank you so much, Emily. I really appreciate you coming on and speaking. And I was looking in the chat and I see that we have a few other families with the team with TMJ issues. So I know you're probably going to get some questions at the end. And I just really thank you for sharing your story. And we are all rooting for you to have that jaw surgery come to fruition and to get that done. And I know you'll do it bravely. And we are all here to support you through that as well. So now I'm going to introduce our expert speakers, our other expert speakers, Dr. Marinka Twilt, pediatric rheumatologist, and Julia Brooks, pediatric physiotherapist, both from the Alberta Children's Hospital. Marinka is actually going to speak first tonight and Julia is going to speak second, but I'm just going to introduce them both now and then they can pass their presentation over to one another. So Dr. Marinka Twilt is also just an amazing support and role model in the Cassie and Friends community and has really helped us to grow our Alberta Children's Hospital clinic. She trained in the Netherlands, then came to Toronto, and she landed at Alberta Children's Hospital in 2015, where she runs the Autoinflammatory Disease Clinic. And Marinka's specific areas of interest are personalized medicine in rare rheumatic diseases and also MSK imaging, with a particular expertise and interest in the TMJ joint. So a perfect speaker for us today. And another really amazing thing about Marinka is that she is dedicated to helping to mentor the next generation of young scientists and clinicians. And I think she just couldn't be a better person to do that with her warm, bubbly personality. Julia Brooks, physiotherapist at Alberta Children's Hospital, has also contributed so much to the Cassie and Friends community. And you might actually recognize her name because she's been in a past virtual education webinar, and she also contributed a backpack fitting guide on our website. So please do check that out if you are returning to school and your child is using a backpack. She's, as I mentioned, a pediatric physiotherapist at Alberta Children's Hospital. She received her Bachelor of Medical Rehabilitation and Physical Therapy in 2003 from the University of Manitoba. She's also been an amazing volunteer for the Arthritis Society camp in Alberta, and we are very excited to have both Marinka and Julia here to join us. So with that, I will hand it over to Marinka and take it away.
Thank you so much, Jennifer, and thank you for inviting me. When I was preparing this talk, I was thinking about how long I have been interested in a TMJ, and I've actually been doing research in TMJ-associated arthritis for the last 20 years. So I was like a little surprised by that when I was preparing for this, but that explains the gray hair that is slowly starting to creep in. So the TMJ for us is really a bit of a jawbreaker, not only for patients, but also for physicians. It really is a very hard joint for us to examine, and also a really hard joint for us to see anything clinically. So I just wanted to say that I'm not a radiologist. I will discuss some of the imaging that can be done. I'm also not an orthodontist, although I will dip my feet into some of that treatment as well. And I'm also not an oral maxillofacial surgeon, but all of those could potentially be involved in your care if you have TMJ problems during your disease course. So just to go back a little bit, how long ago did we know that this started? And actually, Diamantberger in 1890 already described mandibular underdevelopment, he called it, in juvenile arthritis. And Still, who is actually the Sir Frederick Still, where systemic JIA Still's disease was named by, in 1897, described arthritis in 3 of the 5 patients that were in his original publication on Still's disease. So we've known about the fact that the TMJ can be affected for a very long time, but for the longest time, there was actually nothing in the literature on TMJ arthritis and JIA, and it was a little bit the under-recognized joint in juvenile arthritis, and probably because, as Emily said, it is really hard to, it's a strange joint, it's difficult than other joints, and it's not as visible as a knee or a wrist or an ankle that is swollen. But now if you look at PubMed, which is sort of like our big literature bank where all the publications that come out are stored, then you find more than 5,000 publications on TMJ arthritis and juvenile arthritis. So there for sure has happened a lot in the last sort of like 20 to 30 years. So just to look at the TMJ, what is so special about the TMJ? And Emily alluded to it already a little bit. It's the only joint in our body that cannot move independently. If you move the right side, the left side has to move. There's no way you can move the right side without the left side, unless you're dislocating the joint, but that's not recommendable. And then it's one of the only joints with the knee that has a disc that needs to move sort of like fluently during the movement. And that disc can sometimes cause troubles as well. And that's independent of arthritis. A lot of young people complain about clicking, and that has to do with this disc. And there's a lot of like disc anomaly in the just normal population. But of course, that makes it even harder for us if you also have arthritis to know exactly what is going on in your jaw. The other thing is the TMJ really has much more mechanical loading than any other joint. You know, if you bite in a steak or if you bite in chewing gum, which none of us should do, not just Emily, none of us should chew chewing gum, you have lots of mechanical loading in your joint. And then it's also overused. I'm using it now, talking to you. You're probably yawning, listening to me, and we're all using this joint more than 2,000 times a day. So you can imagine that that is a lot to ask from one small little joint, or 2 small little joints actually. And then another thing that is unique of the TMJ that is not found in any other of the joints is that the growth center is really superficial on that condylar head, where in other joints, such as like the knees, or at least the upper and the lower leg, the growth centers are like not as superficial. So they're lower in the bone, which means that if there is a little bit of inflamed synovium on that condylar head and the growth plate is actually affected by it. And that's why we see relatively severe growth abnormalities in a TMJ that you don't see in any of the other joints that sometimes are much more involved than the TMJ. And then luckily, there is now also studies that show that there is condylar regeneration, which means if you have at one moment damage on the condyle, it can actually disappear and it can become normal again. It depends how severe the damage is, how much can come back, but it is possible to have regeneration, which is great because we, for the longest time, thought that that wasn't possible. Who is affected? That's always the question, of course, because I wish I could have this crystal ball and I could tell any patient who comes to clinic, you will develop TMJ arthritis, you won't. Unfortunately, we can't. And the numbers in the literature range from like 17 to 87%. And that has to do with like what imaging technique or what clinical sign do you say you have TMJ arthritis. So a lot of the old publications just used radiographs, these orthopontomograms that are made by your dentist usually once a year, where you see that whole sort of like tooth smiley face on your radiograph, that only shows damage, so no activity, which means that you have a much lower percentage of patients that would show an abnormality on that, although they do have active TMJ arthritis. Where on the other spectrum, we have the Gadolinium Enhanced MRI, which is the gold standard at the moment, which shows much more inflammation, and that's where the higher numbers come from. That can be very small inflammation that might not even have to be treated, but it picks up inflammation much more, and that's where this strange range of like 17 to 87 comes from. All subtypes can be affected, so it's not that if you have a certain subtype, you're completely protected. It does seem to be that patients who have the HLA-B27 subtype, the enthesitis-related arthritis, have a little less risk of developing TMJ arthritis than if you have one of the other subtypes, but none of the subtypes is specifically protected to develop TMJ arthritis. And then the unfortunate is what Emily also said already, that by the time you have symptoms or you have clinical findings, there actually is already associated damage, so you're too late to really prevent anything. And what are the growth disturbances that we see in the TMJ? So one of them is called micrognathia or rhizognathia, which is this retraction of the jaw. It's also called bird face appearance because it looks a little bit like bird face, that you have like almost no chin on examination, but it really depends on if you have one side affected or two sides affected, because if you have one side affected, you have deviation. So that's what Emily was alluding to. If you open your mouth, it actually goes to the affected side, because the affected side is where the condyle is shortened. So your mandibular ramus is shortened, which means that it's not as big as the other side. And you can imagine if something is smaller and you open both sides, then it goes automatically to that smaller side. So in this boy, it means he's looking towards us. So his left side is affected. This is smaller than the right side. And that's why he has the deviation of his jaw to the left side. And this is a picture of a girl who has bilateral involvement. And that's when your knee, you're starting to have this retraction. So clinical examination inspection is one of the first things that we can do. So what we do is look for that like closed mouth micrognathia, rhizognathia, or that frontal facial asymmetry. So in that's the lower picture, you can see that if you would look from the side, she looks actually quite normal. She has no micrognathia, no rhizognathia. But if you look from the front, you can see that she's asymmetric and that she has, again, on the left side, a shorter mandible than on the right side. Then open mouth examination is very important as well, because sometimes you look relatively symmetric when you close your mouth, but then when you open your mouth, you see a really big deviation to one side. Some patients or some people open with a little bit of an S, so they seem to go deviate and then they go back. That's normal. A lot of people have that due to some disc problems. But if you open wide and it remains asymmetric, then it's another issue. You always have to remember to do it a couple of times, because just one time could just be that your disc is interfering a little bit, but if it's consistently there, then you have a deviation of your mandible. So there has been a group that now, it was used to call Euro TMJ joint, but that was too exclusive of North American people. And when I moved to North America, I of course still wanted to be involved. So from Euro TMJ joint, it's now called TMJ. It's a group of rheumatologists, radiologists, maxillofacial surgeons, orthodontists, and some other allied health, as such as dentists or a gnathologist that are really involved in TMJ or temporomandibular joint examination. They really have done their best to identify what kind of clinical orofacial exam should be done in juvenile idiopathic arthritis, because it's actually not taught to us in medical school. It's taught in the school for dentistry, it's taught to oral maxillofacial surgeons, but rheumatologists are not taught to do an orofacial exam. It's now, but not in the old days, because we were just, as I said, there was no literature. It was an under-recognized joint. Now everybody should probably do an orofacial exam every time when you come to clinic. And what do we measure when we do this orofacial exam? Mouth opening. So mouth opening is actually one of the things that we feel is probably the sign that gives us the best information of anything is happening in your joint. So you can measure the mouth opening with a ruler or with a therabite, which is a specific instrument for it. And it's not useful if you just do it once. This needs to be done every time you come, because then you know if your mouth opening changes or not. And not every patient has the same mouth opening, everyone with the same age. So you can have a 3-year-old who has like 35 millimeters, and then you have another 3-year-old who has like 45 millimeters. So there's a wide range for children of the same age. Therefore, we can also not recommend a real cutoff of mouth opening. Although if you're below 40 millimeters, then we think you probably have a little bit of a decreased mouth opening. And really, we recommend longitudinal follow-up of the maximal mouth opening. And in some countries, they have a fantastic healthcare system. So the Swiss, actually, dentistry goes to Swiss schools every year to see the patients. So what they've done, they actually did mouth openings in all school age kids. So they were able to put these really nice sort of like growth mouth opening charts for us to say, if you're 4 years old, then your mouth opening should be sort of like here, but this is the normal range of what patients or kids, at least in Swiss schools, show. And then if you're 17, it automatically goes up a little bit, because the older you get, the more the wider your mouth opening is. As you can see as well, it's for boys, because boys tend to have a little bit of a bigger mouth opening than girls, as you can see. So that's why they even identified it for boys and girls, to make it even more precise. So this helps as well to potentially plot your mouth opening on when you are seen in the rheumatology clinic. And then clinical examination is also palpation. So you can, like Emily alluded to it as well, it's a difficult joint because it's like a round joint. So a part of it is inside your mouth, which, you know, it's hard to feel. But if you put both of your fingers sort of like at the beginning of your ear, and you go a little bit anterior and you open your mouth, you actually can feel the joint space yourself. And it's really important to palpate that for tenderness, for clicking or crepitus. So crepitus is that feeling of like snow. And then also to feel if you have a translation. So if you have the movement of the jaw, you actually should first rotate and then translate. And that's what you can feel yourself. If you would put your fingers and you open wide, you first feel a little bit of a rotation, and then you feel that translation where it feels that your bone is sort of like popping out a little bit. The first thing that disappears when you have like really inflamed joints is the translation. So that's something, that's why the doctor always asks nowadays to take your mask off and to open your mouth when you come to the clinic. And then we can also auscultate. So we can auscultate with our stethoscope, but you can also tell us if you have clips or crepitus when you open your mouth. Clicks are very common, so clicks are nothing to be worried about, but it is indicative if it all of a sudden appears, and it also helps us to distinct from non-rheumatological causes of TMJ issues. Unfortunately, clinical signs are very rare and unreliable, so a lot of research has been done to it to see if there was anything that really could help us. And pain with chewing or mouth opening, it's not a good sign. So if it's there, you have a chance to have TMJ arthritis, but it's also there without having TMJ arthritis. So it's not very sensitive and specific for the problem. The pain is usually absent in young children. They usually don't complain about TMJ pain. And even in older kids, it's only present in 40 to 20% of the patients. So it's not a good measurement. And then function. So mouth opening is probably longitudinally the best one. If you have all of a sudden a restricted mouth opening or change, it helps us. The impaired translation as well. And then the TMJ crepitation sometimes says something, but not always. And then, of course, the asymmetry that we can see as well. And then condylar growth abnormalities, not really something that we can see. That is really something you can view on imaging. So imaging, the gold standard really is the MRI. And why is that? You do have other imaging. So we have like radiographs, which are orthopontomograms and cephalograms, and orthopontomograms can be made in every dentist clinic, and cone beam CTs. These are really good to detect bony changes, specifically the cone beam CT. If you would go for surgery, and I'm sure Emily will say that she has had a cone beam CT, because cone beam CT really helps the maxillofacial surgeon to plan the surgery, because they can have a really good view in 3D on what it looks like, what you look like, and what your condyle looks like. It unfortunately doesn't say anything about acute inflammation, so it doesn't help us as a rheumatologist to say there's still something we can treat, because you can have damage, but you can have no active inflammation, and then you don't need any other treatment. But if you have active inflammation on top of your damage, you might still need treatment. Ultrasound is really good for other joints, unfortunately for the TMJ, because part of the TMJ is in your mouth. You can only see the lateral part of your TMJ joint, and it's round, so there's a whole part on the inside, and there's also two components due to all sorts of tissues that are the disc and other tissues that are in your TMJ. It can show acute inflammation. It can show chronic bony changes. So you would think it's fantastic, but unfortunately, it's not very sensitive, and it's very, very dependent on who does the ultrasound, and it almost has to be the same person every time. And then the MRI. So the MRI with contrast is really the gold standard. It shows acute inflammation, it shows the chronic bony changes, and it can really tell you about the disc as well. Is the disc in the right position or not, or is the disc not in the right position? There is some unfortunate about the MRI as well. We heard from Emily already. It takes a long time. It's very lengthy, which is really problematic if you're young. It's also more expensive than some of the other tests. And then you need to sedate the young kids sometimes because it is so lengthy. There are a lot of efforts to try to reduce the MRI, but because you need to see so many parts of the joint, it's really hard to do a quicker MRI. But we are always trying to see if we can get anything off it. So what do we see on the MRI? So we see the acute changes. So what is that? That's synovial enhancement. So that synovium is that tissue around the bones, and it's also around the bone in the around the condyle in the TMJ. And you can see that synovial enhances, which means if you put that gadolinium in, it sort of brightens up. You can see synovial fluid, which everybody has to have in their joint, because otherwise it would be very hard to move your joint. But you can have how much fluid do you have there? And then synovial thickening, which shouldn't be present. Pannus means really a lot of synovial thickening, and then bone marrow edema. And then chronic changes is really more damage. So that's the condylar flattening. So your condyle should be really nice and round, but sometimes it's completely flat. Little erosions, which are little tiny bites out of the condyle, disc abnormalities, and then also heterotopic bone formation. So some patients will get bone formation not on the condyle where it's supposed to be, but somewhere on the side, which sometimes actually prevents you from opening your mouth. What about braces? Because a lot of children go and have braces. And what if you have braces and you need imaging? So luckily with the newer braces, there is less and less interference. Sometimes the coils still give the tubes of the braces still interfere, but the stainless steel brackets are usually not a problem. And the ceramic braces interfere even less, let alone if you have Invisalign, because you can just take it out. So that's even better if that's possible. Just mention it to your orthodontist if you would go for braces that you do have JIA, so they can take it into account that they don't put any of the, if not needed, any of the braces in that potentially could interfere with a TMJ, with an MRI. So what about treatments? So we have some options for treatment. So we can do locally. So we can inject, Emily said as well that she had corticosteroid injections. We can sometimes not inject, but lavage. So that means that, you sort of put some fluid in, take it out, put some fluid in, take it out, and then you sort of hope that you take that inflammatory components out of the synovial fluid. Then you can treat systemically with medications that you use for the other joints as well, so methotrexate or biologics such as Enbrel or Humira. And then, of course, mechanical. So we could do splinting, which is usually done by dentists or orthodontics, physiotherapy, or orthognathic surgery, which was also discussed by Emily already. So what about corticosteroid injection? So it used to be probably 10 years ago our go-to medication. It was it worked well. You have a lot of relief of pain. It settles the acute inflammation. And most of the kids actually have an improved mouth opening after injection. So it really does something for the inflammation. Unfortunately, though, it seems the results are very short-lived. So after a couple of months, it was sort of gone already, the effect again. It doesn't stop progression of the chronic changes that we see, the damage that develops. And then in the beginning, there were studies in mice and rabbits, and then later now also in patients that shows that there actually is a larger interference with growth and deformities of the mandible when you use corticosteroid injections than if you don't use it. So probably because of the fact that that growth phase is so superficial, and then if there is any interference there already due to the inflammation, the corticosteroids could potentially cause even more growth abnormalities. Then another complication is skin atrophy. So some patients get like a little bit of like a dimple, and the skin sort of like is less thick there because of the prednisone that was like sort of like released in the skin. And some patients have this calcification or the heterotopic bone formations that I was talking about after injections, which is not seen after one injection. You have to have repeated corticosteroid injections for that. So the sort of like international approach has changed. So now we sort of like not recommend intra-articular TMJ therapy if patients are not skeletally mature. So if young patients, we only recommended then for really refractory or very symptomatic TMJ arthritis, because it does really take the symptoms away. And we do say that it may be indicated in patients that are skeletally mature patients. What about other therapy options? So I said a little bit about the systemic treatment. So in the longest time, there weren't really good studies to show, do these systemic treatments really affect the TMJ? There's no reason to think it doesn't, because why would it not affect the TMJ, but it does affect your knee or your wrist or any other? So luckily now the Swiss group has showed they actually stopped injecting, because they were also the first group to show that these injections could cause some problems. They stopped injecting and they actually looked at patients receiving systemic treatment, and then they compared them to their historical cohort of patients that had in the past received corticosteroid injections. And the growth in the patients that received systemic treatment is exactly the same as normal patients. And in that other group was actually reduced, so they had less growth over time. So it was 38 patients. The age was 9 years, so they were young. And then the MRI grade of inflammation improved, so they had less bony involvement. And the mandibular growth rate was not different between TMJ involvement and non-TMJ involvement in the group that got treated with systemic treatment. So they were really, which sort of like suggested that systemic treatment is good for TMJ arthritis. So other therapy options, so splinting. So I actually worked in Denmark for a while, and in Europe, splinting is sort of like the first thing you do in a patient who has TMJ abnormalities. It's also because the insurance situation is different there. Everybody gets it covered, which is of course the problem in more North American centers, that the pricing for splinting can differ greatly between who you go to. So they looked like if we would give a splint to patients with unilateral TMJ involvement, so just one side of the TMJ was in was affected, if they would give what is called a distraction splint. So it's a very hard acrylic splint that preferably is on your upper teeth, not your lower teeth. And what it actually does, it sort of like makes an ice rink. So you can't, like your lower jaw cannot find any real bite with your upper jaw, and that sort of like makes you relax your jaw, and they think that's why it helps. So they treated for 57 months, and they did a CT, so not an MRI, on baseline, and at 12 months, and they really saw that there was actually less asymmetry. So there was like more height again in the affected site than there was in the beginning, so it really helped for patients with one-sided TMJ arthritis. And this is what a splint looks like. So it's not as invasive as some of the older splints were, and it can be on the lower or the upper teeth. Upper teeth is a little bit better than lower teeth, but sometimes you slip a little bit more when you have upper teeth. So sometimes it's better tolerated on the lower teeth. You do have to wear it though for at least 18 hours a day. So you potentially could not wear it to school, and then you have to wear it the rest of the day. They also looked at stabilization splints, which is almost the same, and they treated that for 8 weeks, and there was a lot of like less pain intensity and frequency in patients with TMJ function. So that was also a really nice study. And so it was a safe, reversible, low-cost treatment in Denmark, but I don't think that's always the case in North America. Another theory, like we spoke a little bit about orthokinetic surgery, at least Emily did already. So if you have an end-stage deformity, orthokinetic surgery is really based not on MRI appearance. So some patients have horrible MRIs, but their function is good and their aesthetic is good. So then there's no reason to do an operation. The operation is really needed if you either have functional issues or if you have that retracted jaw and you would prefer to have like a normal position of your jaw. And then there are sort of like 3 options that are possible for surgery. So you have orthognathic surgery, you have distraction osteogenesis, and you have TMJ reconstruction, which can be either alloplastic or autogenous, which means you either can use a little bit of bone of your own, or you can use bone if not your own bone, or it's usually actually just a graft. I'm not going to go into more detail because it's just not my specialty and I don't want to say anything that is not true, but those are sort of like the 3 options you have in surgery. So what about a long-term outcome of TMJ arthritis? So TMJ arthritis can develop also later in the course of the disease. So if you don't have it when you are diagnosed, it doesn't mean that you cannot develop it. You can have that the deformities may improve over time, so there can be some regeneration, and then improvement is associated with lower overall disease activity. So if your arthritis was well controlled, then probably your TMJ is also better controlled. And then if you have a better mouth opening capacity, that also is associated with sort of like long-term improvement over time. We have to consider that most of these studies, although we are in the biologic era, are done pre-biologic. So there are some new studies that are being released soon that shows data of patients that were treated in the biologic era. And what I've heard and what I've sort of already have seen is that they're better. So there is still patients who have, a lot of patients have TMJ arthritis to develop it. There's so much damage, it will not get better. But the amount of patients that get severe TMJ arthritis is less due to the better medications that we have. And that's what maxillofacial surgeons will say to you as well. They don't see that many patients anymore with that severe micrognathia that we used to see 20 years ago. And there's also a decline in the maxillofacial surgery that is performed due to that fact. So we're doing good things, but we're not there yet with the TMJ. So now I'm going to hand it over because there is one other form of treatment, physiotherapy, but I am not going to talk about that. I'm going to leave that to Julia, who's much better in doing that than me. So I'm going to stop sharing so that Julia can share her presentation.
Hello, everybody. Give me 2 seconds here and we'll see what will happen. Okay. Oh, right. I forgot about that. Okay. I think we're just going to try and, hold, please hold. Of course, we need to have tech issues because that's how it works. Okay. Interesting. Sorry, team. Okay, well, I'm going to try and do this, and my computer's being difficult, so we'll see how this goes. And sorry, you're going to see all my slides because this is how it's going today. So I'm Julia. I wanted to say I've just kind of started delving into the world of TMJ arthritis in the last little while. There are many physios often in private practice who are very experienced in TMJ treatment. The one thing I found though in speaking to them is that they don't have much experience in the world of TMJ arthritis, especially in pediatric patients. So most of the TMJ dysfunction that they see is often related to car accidents and things like that. And so when I've kind of looked into it, there's not a ton of really good research specifically related to physiotherapy in TMJ arthritis in pediatrics. And so a lot of practitioners aren't really sure how to translate all of the evidence around TMJ physiotherapy into this population. So these are a few different tips and tricks, and hopefully some of it will be helpful. Oh, come on. Okay. So the treatment, as I said, is similar, but not the same as the physiotherapy that we would use for an injury or car accident or general TMJ dysfunction that many, many people in the population experience. There's a different mechanism of dysfunction. So as Marinka mentioned, we have inflammation in the joint itself. So that's swelling or fluid that's in the joint. We also have the lining of the joint, which Marinka also mentioned, the synovium. So that's a little kind of like a little balloon, I describe it as, going around the joint, which contains the fluid that becomes thickened. And so that also takes up space. And when you have a very small joint, that's going to impact that. And that is not what we see in patients that have TMJ injury. So it's a different mechanism of dysfunction. And again, as Marinka mentioned, in kids, we have open growth plates, and so that can greatly impact how the jaw is growing as well. The main goals of physiotherapy are to reduce pain, improve the muscular function and the overall function of how the jaw is working, look at activity modification, and trying to prevent that range of motion loss or that mouth opening loss, which is really important in being able to eat and interact with people. And also in outcomes, as Dr. Twilt mentioned. Physio is never done in isolation for pediatric TMJ arthritis, because we really know that the medications, especially the biologic medications, are what is going to make the biggest difference in preventing some of those chronic changes. So we always do it in conjunction with some sort of medical treatment, and sometimes with splints or orthodontic intervention as well. And Marinka sort of already mentioned the assessment piece of this. So it is very difficult to demonstrate TMJ exercises because you need to use your mouth and talk at the same time. So I'm going to talk and then show, and we'll kind of go back and forth with that. So one of the big things with looking at TMJ exercises is to try to encourage the jaw to move in a straight line rather than to deviate. And one of the tricks for that is actually positioning the tongue on the roof of the mouth. So you can see in the bottom corner there, this lady has put her tongue on the roof of her mouth as she's opening. So the first exercise that I usually start with patients is just opening and closing to their limits. So that might even be 5 or 10 millimeters. It may not be very far, with the tongue stationed on the roof of the mouth and focusing on keeping the teeth in alignment. Sometimes we use a mirror. So as soon as that jaw starts to deviate off, then we stop the movement. So we're not encouraging that that sort of altered movement pattern, and then we return to the starting position. So basically, is how it would look. My TMJ is not great. I don't have arthritis, but I just have bad TMJs, so I might have a little bit of a wonky jaw as well. The other thing that we know about TMJ exercises, as Marinka mentioned, it's a very small joint and it gets tired easily. And so usually when we prescribe these exercises, we recommend doing a small number of repetitions, but more frequently throughout the day. So I often tie it to a meal time or something that kids can kind of tie it to something that they're already doing during the day. So breakfast, lunch, after school, bedtime, or dinner time, whatever, and doing a small number, but more regularly. And that seems to be more effective in the treatment of TMJ. The second one is the same concept. So the tongue is on the roof of the mouth, and then you're going to move side to side. So I will demonstrate again. So there's muscles that sit on the side of your jaw that can get quite tight when there's alterations in the jaw function. And so this helps to make sure that those muscles are kind of getting stretched out and the jaw is able to move normally. There is a recommendation that you use. So in the past, people have talked about using a wine cork. And I was like, of course I have a wine cork. I love Friday night wine, but you think I could find a wine cork today? No. So sometimes I get people to use a marker. And so basically what we're doing is we're allowing the teeth to rest so that the muscles can relax a little bit more and help to guide the movement. So it basically looks like this. You stick the marker in your mouth, get the tongue on the roof of your mouth. So if you don't have a wine cork, a highlighter does just fine. And then once I have patients getting a little bit more comfortable with that and they're not having much pain with those movements. Oh, and I just want to back up and say that you want to make sure that those movements are relatively pain-free when you're doing them. So I only get people to move as far as they have pain-free and can control good movement in their jaw. So that could be a really, really small movement to start, and hopefully we can progress over time as the medications start to work and as the muscles kind of start to balance out a little bit more. Once we have that sort of those range of motion or gentle movement exercises, then we add some resistance. And so there's kind of two levels of that. So one is what we call isometric movement. And what that means is that you're putting pressure. So you're having, it's like an arm wrestle. So nobody's moving anywhere. It's completely stationary, but there's pressure coming from each side. So you're trying to open the jaw, but the hand is going to give counter pressure so that the jaw doesn't actually open. And the jaw dictates how much pressure. So the hand just meets the pressure of the jaw. You still, again, have the tongue on the roof of the mouth. It's not going to look like much. So you've got your tongue in there. And then you relax. You might hold for 5 to 10 seconds or to tolerance. And then you would, again, add that to your side-to-side movements or your lateral movements. So you can do it with a cork in your mouth, or you can do it without, but essentially putting your hand on one side and then pushing against it and then relax. So that would be the next step in the progression. And often we don't stop the range of motion exercises to add in the isometric exercises. We do them in tandem and we kind of see how things are going. The third level of that would be resistance with movement. And so you would do the same thing, tongue on the roof of the mouth. For opening, you would have pressure here, but now you're going to allow the jaw to open. So the hand is going to let it go, but there's going to be sort of a pressure on the jaw as it's moving. So it's going to look like this. And then same thing with the side to side. So those are kind of the at-home exercises for the jaw in particular. I do try to get my patients to do some oral massage, which almost nobody wants to do, shockingly. When I test this in my office, I use a glove. And at home, I encourage people, if they feel more comfortable, to use a glove. But the muscles around the jaw can often get really, really tight, especially on the side where there's less movement happening. So there's more arthritis on that side. And if we can get those muscles to relax, often we can have a little bit less pain. It is a little bit uncomfortable to do the massage and it looks a little bit weird. So basically you take your thumb and you stick it right to the back where you kind of feel that point where the mouth is opening, and then you put pressure on the outside. So, and then you give it a nice massage against your fingers. I don't have hand sanitizer. This is very not COVID friendly. I'm sorry. You can also do, if you're not keen on doing the intraoral massage, you can also do extraoral. So that just means on the outside and rubbing around in circles and along the jaw to wherever it's kind of feels a little bit uncomfortable. Whenever I give my patients this, I always talk about how it'll feel a little bit uncomfortable, and that's what it should feel like. It shouldn't be like, oh, this is so lovely, or oh my gosh, I'm in excruciating pain. There should be that kind of balance where, yeah, that doesn't feel great, but it's manageable, so that we can get those muscles just to relax a little bit. A lot of people, so just like any other joint with arthritis, we can get stiffness in those joints. And sometimes even before the massage, it can be helpful to just put a little warm compress. I found some delightful pictures online of these beautiful head wraps that if you really want to wear them, I'm sure Emily would adore wearing them to class. They kind of go all the way around and provide heat or ice as you want. I picked this other lady who's got a nice hot pack and she looks very happy about it. You can do something as simple as take a washcloth, get it wet, put it into a Ziploc bag, and then put it in the microwave to the desired temperature. You want to test it before you put it on your face so you don't get burned. But it's a nice warm, moist compress, which often people find is really nice. And then we can't ever speak about the TMJ and physiotherapy without also addressing the neck. So it's very common that when the TMJ has dysfunction, that then the neck also starts to cause problems as well, or vice versa. So they kind of feed into each other. So there's different exercises that we do, and they're very difficult to demonstrate. You can see the middle picture here. This gentleman is lying down and he's doing what we call a chin tuck, or activating the deep neck flexors. So the deep neck flexors, that's a tongue twister, are as the name sounds like, deep inside the neck rather than these big, strong neck muscles that we can all see. So these neck muscles tend to take over when there's neck or jaw dysfunction and they are working too hard and they actually can pull things kind of not in the right way. So working on those smaller, more stabilizing muscles that are deep inside can be really helpful. Doing some neck stretches can also be helpful. And also just working on just postural correction can be really helpful. So that's kind of it, a bit in a nutshell. My little tips and tricks. So these have kind of been alluded to by both our speakers so far, but just to kind of go into a few extra things. So cutting chewy food. So I usually talk about like meat, especially steak. So thinking about how tough it is to chew steak and how much work that takes, cutting that into really small pieces so that you have to chew for less time and it's easier to swallow with less chewing. If the food makes you open your mouth really wide, so things like apples and bananas, or not bananas, bagels, where you have to do that really big opening, cutting those into small pieces, cutting them in half, so that you're not doing that complete wide mouth opening and then trying to chomp down. You can also try, a lot of people complain that when they sneeze or when they yawn, that really bothers their jaw. So just giving a little bit of gentle support on the jaw as you're yawning or sneezing can be helpful, just to kind of offset the stress that's going through the joint. You can try and sort of stop yourself, but sometimes then you're sad because you don't get to sneeze or yawn, and that's kind of disappointing sometimes. Avoiding, we've talked about the chewing gum. I love chewing gum, so I feel sad about this. Mints are a great other option if it's a breath issue that you would like. Things that are very tough to chew, so things like toffees, where it's just like you bite down and it's like really difficult, and then you're opening against it and there's a lot of extra jaw work. Clenching the jaw, so if you're a jaw clencher when you sleep, often those nighttime devices the orthodontist can give you can be helpful with that. And then this girl in the middle is kind of resting on, so we often do this if we're listening to somebody or attending to something on television, and that can be quite stressful on the jaw as well. So a few things to try and kind of avoid. I did put this question slide here, but that's going to be addressed shortly. So that is all I have to talk about right now. And I will stop sharing my screen.
Thank you so much, Julia. This is the best session ever because I just spent watching your presentation. I was stretching, I was massaging. I feel great, actually. I'm going to invite all of our panelists to turn their cameras back on, and we're going to start our Q&A session. So if you did have a question and you haven't had a chance yet to put it in that Q&A box, we'll give you a second, and please do ask anything. And if you have sort of specific questions about the exercises, etc., or the information that Emily or Marinka also presented, this is your time. I thought, Emily, actually, you could maybe kick us off. Are any of those exercises ones that you've tried, or like ones you particularly liked or didn't like? And I thought you could share a bit of experience around that.
I really like the jaw massage personally. That's something that I like to do. I carry a lot, obviously with having TMJ, I carry a lot of tension in my jaw. So I really find like massaging that joint, even like dragging down from here, that's something that I find really helpful. And also doing, it looks kind of ridiculous, but doing like facial stretching, if you will, is also something that I find, like really stretching the mouth open, like wide like that, just to kind of get that movement going. That's something that I personally like to do.
Awesome. And any tips like the cutting the food, or I know someone, another youth once told me that for her, like the wide mouth water bottles were not good. So she tried to find great ones with the straw. Any sort of things like that you suggest?
Yeah, definitely. I really like the straw water bottle, or just like the smaller sized ones. I think that's super helpful. Cutting up food is definitely helpful. I still don't chew gum even after I was scared off of chewing gum. I still avoid that personally, but again, you know yourself best. So I like avoiding, not necessarily avoiding chewy food, because you can still enjoy those things, but definitely like cutting it, watching how things are cooked if it's easier. And again, with lots of joints with arthritis, some days are going to be better than others. Some days your jaw is going to be able to maybe move a little bit more. So really gauging and doing what you need to do on those days.
Awesome. Thank you. One of the questions actually that just got typed in could be another good place to start, which is, what is the difference between TMJ issues in people with JA and people without JA? And I wonder if, I know Marinka has been studying this for a long time, but I feel like Julia might know the answer too. So maybe we'll start with Marinka and then Julia can weigh in.
That's a very good question. I mean, the TMJ is a joint that a lot of people actually have trouble with, and that makes it so difficult. So it's called temporomandibular disorders, TMD. And TMD is like, that's where all the people in the maxillofacial surgery waiting room are complaining about. That's most what they see, right? And it has to do with all the musculature that is around the jaw. And it's really hard for us to differentiate between. And specifically, if you have on your MRI a disc that is not in the right position, it's hard for us to say, do you have inflammatory symptoms on your MRI due to the fact that that disc is not in the correct position, because then you have like, rubbing of like bone on bone or rubbing of like bone on not the disc. Or is it because the disc is displaced because you have arthritis? And it's really hard for us to find out what the chicken and the egg is. And this is one of the things that we're trying to study. We have a study going on both here in Calgary and in Edmonton to look at that, to see like, can we see if the patients who have real diagnosed juvenile arthritis and develop this disc that is not in the right position anymore, do they have more inflammatory changes than the patients who have that not? But unfortunately, specifically girls or young women are more prone to have TMD, so temporomandibular disorders. So the clicking, they think it's because of the fact that the tendons are a little lax, and that's why that disc is sometimes a little bit displaced. And of course, we have more girls in juvenile arthritis as well, which doesn't help. So it is difficult to differentiate between, but there are some, and Julia can probably take this over from me, there are some things that, you can differentiate, because TMD usually is mostly muscles. And if you do some of the muscle palpation, you'll notice that that is where the real issue is, and not in that TMJ, where Emily really says, if I massage my TMJ, it helps. The patients who have more TMD will say, oh, it really is here and it goes through my head. But Julia, maybe you can add a little bit to that.
Yeah, I think it's tricky because I would say that in my practice, just because of we're a tertiary center, we don't see a lot of standard TMD problems unless the patient has an underlying diagnosis of juvenile arthritis. So like I would say 99.9% of the kids I see that have TMJ problems have juvenile arthritis, and it's diagnosed and they're on treatment. But speaking to the community providers, certainly, as Marinka said, there's a lot more muscular release kind of involvement or muscular release kind of intervention that you can do that would actually be beneficial. I also feel like our kids really improve. So a lot of what I'm doing up front in terms of the treatment is prevention and to try and minimize pain. And then once the medication's working, then we're trying to improve function. Whereas with TMD, it's not going to change with medication. And so a lot of the work they're doing up front is to enhance their function immediately. Obviously, they're trying to reduce pain as well, but it's just a little bit of a different approach just because of the extra medical treatment that goes into our kids with TMJ arthritis.
Thank you. So we have a question that I mean, you touched on the frequency or the rate of TMJ issues in JIA, and I think that this echoes that. But the question is, can there be degeneration of the TMJ with JA? And they said that our daughter has experienced significant issues, and I'm not sure if that means significant issues in the jaw or just like she's had significant issues with her JA, and is this going to now affect her jaw? I know you touched on it a little bit, but if there's anything you wanted to add on that.
Yeah, so if somebody would comment like on the MRI, not knowing a patient has JA, they would say they have osteoarthritis. It looks exactly the same, right? So the bony changes that you see are the changes that you would see in somebody who's 80 and has lived a really great life. So there is for sure degenerative changes. I think we just used the degenerative term wrongly because we always use it for older people, but it just means that the joint is degenerated, right? And it has nothing to do with if you're 8 or if you're 80. But yes, you can see degenerative disease in juvenile arthritis. If you have active arthritis, then the jaw can be affected in a flare, even if you didn't have arthritis before in your jaw. So I think you always have to try to stay in touch with your body. Like Emily said, you know your body the best. And if you notice that all of a sudden, if you yawn, you're getting pain, or if you can't eat that apple anymore. I once had a patient who came in my study in 1999, who came and she was perfect. And we saw her and we were like, you have no TMJ issues. Her x-ray was fine. And 3 months later, she came to clinic and she's like, I can't bite my apple. And we did an x-ray and her condyles were gone. So she had really rapid acute arthritis, but no pain issues, nothing. It was just like, I can't eat my apple. I have to like cut my apple up now because I can't make that movement of biting the apple up. So I think it's really important to stay in touch and to really, there's not that many symptoms, but there are some. So if you have those, please just like call your rheumatologist and be seen earlier and not wait, because then sometimes it can be already too late and damage can have been done.
And with younger kids, is there any confusion around like, kids are picky eaters or they got braces? And I'm sure that's hard for parents to parse apart sometimes. Like, will they not bite the apple or can they not bite the apple?
Yeah. Well, sometimes it's also they play, right? And some kids, most young kids love to put stuff in their mouth and they won't do that. So that's another thing that you can see it as an, they love to, like if they play with their blocks or whatever, they put it in their mouth. So that's one of the things that they might not do anymore. And it's also avoidance of nice food. So like ice cream, right? They won't put like the popsicle in their mouth anymore because they can't open their mouth that wide for the popsicle. So I think if it's the things that they like and they can't open it, there's the big indication, but it is more difficult with young because they have no pain most of the time, and they can't indicate that well, right? And I mean, I'm sure Emily already had TMJ arthritis before she was diagnosed at 6 because she already had that deviation, but she probably didn't notice, and her parents didn't notice because kids are good at adapting, and you'll just like eat that apple cut, like you say, or just don't eat an apple and go to bananas because it's easier. So.
Is there anything you wanted to add on that, Emily?
No, but I definitely agree where it's just you don't have the language for it. And like when you're that young and kids like really do adapt with kind of the way, like a little bit similarly, like when I hold my pencil in a weird way and they think it's because I had arthritis in my wrist before I was diagnosed and I just found a way to hold my pencil that was more comfortable and then I adapted to do that. So I think, yeah, that's definitely true where it's harder for kids. And also you don't want to I find like when I was a kid, I wouldn't want to speak up when things were sore because I didn't want to have to do more blood work and more things like that. Because that's scary when you're a kid. But yeah.
Awesome.
I think I've also seen kids do interesting things with their heads and necks to try and and then you realize it's not actually their neck, it's their jaw. And so sometimes you'll see that they start to kind of like put their head funny when they're trying to eat or move their head a little bit differently. And I usually, when I'm assessing like a really little kid for TMJ, I will try to get them to like make like a dragon face or a lion face and see, and that often will get some really interesting. And so a parent at home could easily play a game where, every day or whatever, not every day, but like every week you make your dragon face and you can kind of check it out and see. So if you have a child that has arthritis, you can have the dragon face day and see if anything's changed. Deviations can be really subtle and they can be really hard to see. So like watching a kid for a deviation, like sometimes I have to like stare at them and kind of like, and I'm like, oh yeah, okay, I guess they do. So that can be really difficult if you're not trained to look for it.
And the other thing as well, so for mouth opening, we of course use measurements in clinic, but a crude rule is the 3-finger rule. And it's like you have to be able to put 3 fingers in your mouth. So that's another thing you can do with your child to see if they can still fit that in. Should be the child's fingers, not your fingers, just to be clear, because I even had colleagues who put their fingers in the mouth of the patient. That's not how it's done. It's really like the patient has to fit their own fingers because they should be small fingers for small mouth openings.
I'm just sitting on my hands because it's extremely hard to hear that and not immediately try and put your fingers in your mouth.
I know.
Yeah, exactly.
My first talk that I ever did, I did all the, like I was talking about how you can do all these like what Julia did, the side movements, and I hadn't noticed that I was doing them all when I was talking. So I was like giving a whole show.
Okay, this is where the like quiz from your presentation comes in, because the question is, my daughter had a CBCT and I feel like it's cone beam.
Yes.
Is it? Yeah.
Yeah.
Yes, I did it. My daughter had a CBCT and it shows flattening and sclerosis of the condyle. Is this arthritis related?
So it for sure could be. So, I mean, flattening for sure is like, we see that in arthritis. The problem is with a cone beam CT, as I try to explain, is you can't see if there's any active arthritis. So you can't see if there's any synovial enhancement, if there's any synovial fluid. And if you would have disc displacement, so that disc is not in the right position, your cone beam CT would look the same as somebody who has active arthritis. So it's hard for us on just cone beam CT to say, is this like arthritis or could this be because you have disc problems? So you always need an MRI to say that. The cone beam CT is really good for the bones. And if you would go for surgery, they will do a cone beam CT because they can make measurements and they can do really cute, really nice things with it, but it's not the right imaging technique to look for active TMJ arthritis. Mm-hmm. It's only for TMJ damage.
Okay, great. And there was one other question, just will a CT scan show jaw joint damage or issues with TMJ? And again, I feel like we know the answer to this one, but do you just want to remind us of the answer?
Yeah. So it can show damage, but it can't show any active arthritis. So, and then the other thing is it needs to be a cone beam CT to really give that beautiful, I mean, those pictures look like, you can see your own face. I'm sure Emily has seen her. Like you can see every detail of your jaw, like from the inside out as well. So you literally see your whole jaw, your whole condyle, the fossa, and that's what they need for oral facial effectual facial surgery, of course, because they need to know up to 1 millimeter what they need to do for your surgery. But it doesn't help us. You can't see the disc because a disc is not a bone. So you don't know where the disc is placed, and then you can't see any inflammation. So you can't see synovial enhancement or anything like that. So it's great if you want to see your bony changes, but it's not good if you want to see if you have any active TMJ arthritis.
Right. Julia, I think you might be able to answer this one best. Someone shared that they had orthodontics, a jaw expander, and twin blocks for 8 years from age 8 to 16 to help move their very recessed jaw forward. And they said they're just asking if that's something that was also used for TMJ.
This is a question for an orthodontist. Mm-hmm. So I like a lot of my patients, if they're still having sort of persistent pain, or if we have that big retroagnathia or microagnathia, we have a TMJ clinic at our hospital that includes an oral facial surgeon and an orthodontist. And so they can go and see them and give, a variety of different options. So it can be, some of the splints that Marinka talked about. Sometimes they'll do something more extensive. I think it really also depends on the stage of the arthritis, like how active the arthritis is, what the intervention would be. So if you have chronic changes versus acute arthritis, there's going to be different intervention from an orthodontic perspective. But we do try to, any of those kids that have that significant sort of microagnathia, we do try to get them to see the oral facial surgeon and the orthodontist, because those interventions start to get more bigger, I guess.
And you might not know the answer to this, but just thinking through Emily's story about not having a pediatric center and being in the adult hospital. And it sounds like Alberta Children's is well set up to deal with this within the hospital. Do you have a sense, because we have people from all over Canada that tune in, like, are there, different resources in different centers, and what should parents ask for?
So from a physiotherapy perspective, and then I'll let Marinka talk about the TMJ clinics, it broadly varies across the country in terms of access to outpatient physiotherapy within the hospital, outside of the hospital. how the insurance structure goes. There are many, like I mentioned, private physiotherapists. I can't even say my own profession tonight, apparently. Who specialize in TMJ dysfunction, but whether they actually have that extra piece of understanding around TMJ arthritis is very variable. And even I spoke to a very prolific expert in Edmonton when I was doing some of my training, and she was like, gosh, I really don't have, like, I can give you the basic TMJ stuff that we do, but she didn't have any resources to give me for physiotherapy in TMJ arthritis. So physio, it varies extremely broadly. So in your clinic, if you have a physiotherapist, you can ask if they have any experience with TMJ treatment, or if they can refer you to someone. If there's not a physiotherapist in the clinic, many of the provinces have provincial registries for physiotherapists, and it breaks down what their specialties are, and then they can access it that way. You can access and find a person who specializes in that, and then they can always communicate with your team if they need that piece about the arthritis side of it.
Yeah, so I think we're actually the only clinic, like the only TMJ clinic in Canada. And it started when I came, because I've been doing like TMJ research for like the majority of my career. And as Julia said, we have the maxillofacial surgeon, the orthodontist, a dentist, and then a physiotherapist and myself in the clinic. And it really is like usually a one-time clinic. It's not like you're coming there multiple times, because if you have to have treatment, you'll go to an orthodontist or a maxillofacial surgeon, or back to your primary rheumatologist. The problem I think we run into sometimes is just there are many orthodontists, and it's hard to reach all of them. So I try in like Calgary, in Alberta, they have the Albertan Orthodontic Society. So I've spoken on multiple of their yearly meetings to make them a little bit more aware of what is JIA-associated TMJ arthritis, but it is difficult. And the treatment that the twin block and everything is actually really good treatment for us as well. It just needs to be done when you're growing, which is if you're 8 to 16. So that is an appropriate treatment. I think sometimes people just forget that the jaw, like it doesn't grow that much more anymore after a certain age, and then these very intense treatments will not work. And it's quite invasive to have a twin block in your mouth, because you literally have like your mouth is sort of like open the whole time. And so, but yeah, those are good treatments. The good thing I think is I'm in contact with lots of my colleagues in rheumatology, so I'm always happy to like communicate with them by email, and they reach out to me. I know that that there are some like rheumatologists also informing their own maxillofacial surgeon. I know that in Nova Scotia, Adam Huber's talking soon, because he asked for some of my slides and stuff like that. So we do share resources. And then the other thing that we've realized in North America itself, because we have CARA, which is the Childhood Arthritis Rheumatology Research Alliance, where a lot of centers are involved. We've actually developed a resource to help train rheumatologists to look at the TMJ, because even rheumatologists still, I mean, I did my PhD for 5 years in an orthodontic clinic on TMJ arthritis, so I am very well aware how to look at the TMJ, but that's not everybody. So I think a lot of people would benefit from having that as a resource to look at it, because I think a lot of rheumatologists still find it a little bit of a black box. And they will do the mouth opening, but they don't really know, as Julia said, the deviation can be very minimal. So there are resources, and we are working as well on an information sheet for families that they can bring to their orthodontist or through their dentist, so that we'll post that on the Cassie and Friends website as soon as it's done. And it has a little bit like, why is an MRI done? What kind of treatments are there? And that your orthodontist is aware, or your dentist, of your JIA. But yeah, it is. We're trying to get more awareness, but it's a big task to like reach all the radiologists, all the maxillofacial surgeons, all the orthodontists. So we started with the radiologists, because the imaging is the most important for us, because that's where we get our information. And then we worked on the maxillofacial surgeons, because they needed to do the surgeons. And now we're trying to do the orthodontist. But the group in Denmark is fantastic. They're doing a lot of like outreach, but it also has to do with insurances, and every province also has different rules again of like what is covered or not. And in countries as Denmark, everything is covered, and that's why you're paying 60% taxes. So yeah.
Well, for all the parents who are listening in today, that's like, I think one of the, like what I find a really special thing about Cassie and Friends is that we interact with all the clinics on a regular basis, and then also the youth and parents. And so if there are challenges that you've been facing at the orthodontist or in any kind of access to care around TMJ or jaw issues, like please let us know, either just send us an email or you can put it in the chat, but that's the kind of thing we can pass back to. And then when you're developing these leaflets, of course, then of course the challenges that people are facing can be incorporated into them, which is awesome. So one other question was, how do I know if I should take my doctor or my daughter to the doctor or the dentist for her jaw issues? And I guess this is like early identification, or even I guess when treatment is ongoing, like just kind of parsing out, when is it the dentist, when is it the doctor?
So, I mean, if you have new problems with your TMJ, you really should go to your rheumatologist and they can liaise with your dentist or orthodontist, but they are the better ones to identify if it has to do with your arthritis or not. If you have tooth pain, go to your dentist, right? Because I mean, the tooth pain is like totally separate. But if you have like real issues with your TMJ or movement of your jaw, you can't open your jaw as much, or you can't even talk. Some patients have that their jaws get stuck in a certain, like, you know, they yawn and then they can't close their jaw anymore. If those things happen, go first to your rheumatologist, and then they can also, you know, there needs to be imaging that happens then, and then they can liaise with your either dentist or orthodontist. And it depends a little. There are dentists that are very comfortable, and there are dentists who say they need to go to an orthodontist, they have to go to a maxillofacial surgeon. And that really depends on where you live, who your dentist and orthodontist is. And I think as long as you have open communication with all the people involved, and most people, you know, we really try to put the patient in the center. So most people are happy to say, oh, I'm happy that you go to the maxillofacial surgeon or to orthodontist if they don't feel that they are the right person to do it. And I can't really comment on like whichever person is in which area, but I think open communication is the best thing. And I'm sure Emily has probably experience with all like dentist, maxillofacial surgeon, orthodontist over the time, but I'm sure they all were very open to like what they knew and what they were like, oh no, please send it to somebody else.
Our next question, I mean, you gave such a thorough like explanation of the treatment options for TMJ, but I thought maybe, Emily, it'd be really interesting to know from your perspective. Like, obviously you were young at first, you were 6 years old, but as you grew older, like what was your experience being included in those treatment options conversations? So like, you know, from medication to starting to discuss surgery.
For me, it was really, it's scary at first, at least in my experience, to kind of start getting involved. Like I was very much the kid in my appointments, like my rheumatologist or the surgeon would ask me the question and I would turn to my mom for the answer, like waiting for her to cue me on what I was supposed to say. But there isn't a thing that there isn't a correct answer. Like you have to have that dialogue. And I think for a long time, like until I got older, I also didn't really understand what was going on. I was just kind of like nodding my head along. I was like, I don't need to get an injection at the end of this appointment. Great. Okay. Like I'm fine with that. But for me, getting involved, it was a lot of asking questions. There's no dumb questions when you're in the room. They'll explain, like, I think when I had my first pre-surgery kind of rundown of how surgery was going to work, I had them walk through every step they were going to do probably 5 times. And I asked, like, how's this going to work? How's that going to work? And then when we were talking about like different treatment options, I'm like, how would that look long term, or how would that work? Like, could we combine it with this? Could I do it? Could I still do this if we did that? Yeah, it was really daunting at first, but it's now something that I feel a lot more comfortable with. And that's just something that develops over time. So if you're in a position right now where you're like, I have no idea, like, I don't want to be, I don't know what I'm talking about or anything like that, it just happens over time, because TMJ, it's a really particular thing. There's a lot of dialogue, there's a lot of terms that are very specific and that the average person probably wouldn't know. But yeah, never be afraid to ask questions is my biggest tip for that. Get them to explain everything to you, because they gladly will, because it's your treatment and they want you to be comfortable with the treatment that you're being given.
It's amazing. I always think of it now as the weird joint, because you called it the weird joint.
It is, it's a weird joint.
2 questions left. So, Marinka, I know you talked quite a bit about steroid use and showed a few research studies, but we'll just recap, or if there's anything else you want to add to it. And the question was about what is the latest research telling us regarding steroid joint injections to the jaw?
This is a very good question. So we actually have guidelines that are made by our American college, right? So for treatment of JIA, and a lot of our Canadian centers follow those treatments. And we actually, for the first time last year, had a specific guideline for Tmj arthritis, which was a big I was ecstatic because we've been working to have like specific Tmj arthritis guidelines. So the guideline for injection is that we would not recommend it for somebody who's skeletal immature. So somebody who's young, we say, please don't do it. And just because the growth issues, and we didn't know that. So if you've had them in the past, like Emily, that's because by that we didn't know then, yeah, right? And then it really was like it does show symptom relief. It's just not good for the long term. So for the long term in patients that are young, we say, please just treat with systemic treatment, potentially physiotherapy, potential splinting. If you're older, and the jaw officially grows until 25, but by, girls usually around 16, 17 won't gain that much growth anymore. And boys are a little later. They're always later in everything. They usually have growth until 18, sort of like, but after that, there's not much to gain anymore. So if you're older and you're most mature, then we say, yes, you can try steroid injections again, and it won't affect the growth. You still would potentially have that heterotopic bone formation. It really is shown in research that if you have multiple injections, that can really be one of the side effects of having these steroids injected. There's still a little bit uncertainty if it's really the steroids or if it's just injecting in the joint. So that's another thing, because nobody really has done a study where they just put a needle in, they don't inject anything, and they have a control group where they do the needle and inject corticosteroids, because you do sometimes go through the disc, right? Because it's a small joint. To put a needle in that small joint, one, it needs to be under CT guidance. If you don't do it under CT guidance, you're probably not in a joint. And then secondly, it's like really difficult to not hit that disc or some of the soft tissue that is there. So you could potentially have some inflammatory response and maybe some growth abnormalities due to that as well. And that's the difficulty that we're still, but at this moment, we say be cautious with corticosteroid injections.
Thank you. So as we know, kids grow up into thriving young adults like Emily, and they transfer out of pediatric care. And ideally, they find an amazing adult rheumatologist who does a thorough examination on every visit. The question is, what is the likelihood of a child developing arthritis in the jaw in adulthood? And I think a good question to add to that is, in kids where it's often asymptomatic or silent, is that in adults as well? And like, what should young adults that have transferred out of pediatric care start looking for or watching for?
That's a great question. And I wish I had the answer, because unfortunately, the TMJ is ignored by most of the adult rheumatologists. They usually look at your hands and your feet because that's what RA is, right? And they already struggle with juvenile arthritis, that they actually have to look at more joints than what they're usually doing in their 70-year-old patient. So we're doing a lot of advocacy. We're trying to let our adult colleagues know that the TMJ can be involved. And I think they can actually be involved in RA patients. The problem is that RA patients have osteoarthritis already in their jaw as well, because they're old, right? And then we have that discussion again, like what is what if you image them. But you can develop it, I'm sure, because you can develop other joints. So why wouldn't you be able to develop the TMJ when you're in adulthood? So I would say just the same thing. If you have any symptoms, and yes, it's silent, but you will notice that you can't open that much, or you're all of a sudden you feel like you're deviated a little bit, look at yourself in the mirror, open your mouth a couple of times. You could potentially do your own mouth opening with a ruler, once a month or once every 3 months, just to keep an eye on it. And then if it's not, go to your adult provider and say that you have TMJ issues. And then they will do imaging. It's not like they don't want to do it. It's just not on their radar. So I think we still need to do better with getting them aware that the TMJ can still be an issue when you're older.
And what about in physio care? Like, as an adult, you're kind of coordinating your own services and seeking physio. Is there, something special you should look for? Will they have jaw, expertise or experience on their website?
Yeah, so I think this goes back. So again, it varies by province, but in Alberta, the the sort of what the province offers is pathetic for adults, unfortunately. So most of it's done through private care. And I would actually say it's probably better in adulthood because most of the private practice physios deal with adults primarily, and they see a lot of adult TMJ issues. Again, they may not be as comfortable with it from an inflammatory perspective, but in terms of the anatomy and the size of the human, they're going to be a little more comfortable with that. So probably your best bet is to go to a TMJ specialist, and there's definitely a TMJ specialist physio in every city, if not more than one, and they would probably be able to address that.
Amazing. So we've gone through all our questions. So I'm going to put you on the spot one last time and just ask each of you, like, for the people that are on the line watching, what you would, hope would be their key takeaway from this session, whether that be the next time they're in clinic or at home, or Emily as a youth with a rheumatic disease themselves. And we'll start with Julia.
I think the key takeaway is just remembering that if you have juvenile arthritis, that you should be paying attention to your jaw, because it's way underdiagnosed, and we don't want to miss it, because then the long-term outcomes can be, quite significant. And we've had patients that have all their other joints look great and they have jaw symptoms, and we put them on biologics only because of their jaw, because we can't control their jaw any other way. So I think it's really important not to forget about that joint and ask those questions if you're concerned.
Thank you. And Marinka?
Yeah, reach out to your rheumatologist if you feel anything in your jaw. I think that's the most important sort of like lesson from this. It is very asymptomatic, so it is difficult, and just bring it up during the conversation. Every time you come, you can say, I have no TMJ issues, or I have, so that you're proactively mentioning it to your rheumatologist so that they are aware of it and they also note it. So it's also in the chart if you all of a sudden get another rheumatologist because yours is not around, or you're in a center where they share the patient load, then at least it's in the chart, because they ask. And the same for maximum mouth opening. You could even ask, can you measure my maximum mouth opening? And if they note it in their electronic medical, they can keep up with it, right? It's hard for you to take it home in a little book, but if they put it in the EMR, then at least an electronic medical system, then at least it's available for everybody. So just proactively mention your jaw at your next visit.
Amazing. And Emily, you get the last word.
I definitely agree with both Julia and Marinka. Just taking note of it, because it is a joint that you can kind of forget about, even though it's something you use quite often. So you do really feel it. For me, I feel it sometimes just drinking out of glasses. I find I need to use a straw instead. I'll talk about self-advocacy again. When you notice it, if you're keeping track of it, it's up to you to advocate for it. Again, it's not like a knee where your rheumatologist can look to it and just automatically see that that's something that's swollen. So speaking up for it, because not speaking up for it, that will harm you more in the long run. But specifically for youth, one thing that I'll say is really utilizing things like Cassie and friends, like the Arthritis Society, and making those connections with other youth who have experienced the same thing as you. Because like we saw in those stats at the beginning, it is such a common thing in kids with JIA or JA to have TMJ issues. So I can guarantee any other kid that you meet at one of those events or things like arthritis camp, I cannot recommend the camps run by the society highly enough. That there's one other kid out there, and just finding even one other person who's had the same experience as you can really make a huge impact. It's something that made a life-changing impact for me, was meeting other people who've gone through the same thing. Just nice knowing that there's other people out there who are going through or have gone through the same thing. A lot of me and my friends are all at that jaw surgery stage now. So we're all kind of helping each other get ready. I have a bunch of friends who just had it, and then kind of the next kind of year, the rest of us are getting it, and then we'll all have our stuff fixed all together.
So great. Well, thank you so much to all three of you for sharing your expertise tonight, your time, and just being here with our community, because I think you're totally right, Emily. Just being amongst people who understand and can relate is life-changing in its own. So thank you guys so much. I'm going to share my screen again and say a few last words, and then I know it's quite late in the East Coast, especially in Nova Scotia. It's 10 o'clock. So just 1 second. There we go. Just let me get back to my slides here. There we go. Okay, so thank you again to our sponsors. You can see them here on the screen, but I just really want to say, we're really proud to have the Arthritis Society as a sponsor to help us deliver this education as well, and to work together to ensure that all the needs of our community are met, and at camp and then all throughout the year, and working together is a way that we can do that. We encourage everyone on the webinar today to please, again, keep in touch, connect with us, let us know what your experiences are, or if there are other sessions you'd like to see. We're planning already for our next series of webinars. And if you have an idea or something that you think has affected you that others might relate to, please let us know. We're always looking for parent and youth volunteers and ambassadors that can get involved at their local center level. And of course, Team Cassie and Friends run walks and other events throughout the year. So really hope that you will get involved and connect. Don't forget about the Juvenile Arthritis Canada Facebook group. If you're not a member, I recognize a few members on the call today, and I think they can attest, like, it's just such a warm community and everyone is always so encouraging and has so much experience to share, especially as we're all back to school, a lot of us, lots of tips and stuff around school communication. And finally, if you are able, we always, encourage, if you're able to consider making a donation. And of course, that can be a donation of monetary means, or it can also be, as I mentioned, getting involved, volunteering, helping us to raise awareness. But we are a nonprofit organization, and we do rely on not only our corporate sponsors, but the families to contribute as well, so that for future diagnosed families, we can keep being there on the ground all across Canada, wherever a family or youth might need us. So with that, thank you so much. I wish everyone a good night, and watch for the recording and the post-event survey to come your way. We'd really love your feedback. Thanks so much. Bye, everyone.